All right, we're ready to begin. Welcome everyone to the next in our series of town halls. We're revisiting the issue of vaccines again today. Thank you for joining us, and I apologize for the technical difficulties. I think we're getting used to that by now. So today we once again have Dr. Alfred Bacon, who's an infectious diseases specialist. And Dr. Bacon's going to give us an update on the state of COVID-19 in Delaware. And I'm going to give an update on where we stand on vaccines and the Department of Public Health in Delaware for the judiciary. So Dr. Bacon, again, thank you so much. We know your workload has been crushing over the last month or month and a half. I'm sure long nights, long days in the hospital, given the peaks that we've had. And we really appreciate the fact that you could take the time and educate us once again on where we stand with COVID-19 in Delaware, and also the exciting news about vaccines. So thank you so much.
Well, Chief Justice, thank you. And it's good to be with you again. I'm going to discuss issues related to COVID-19. My screen share up. We'll do that again. And I trust that the slides are adequately displayed now. If that's a no, let me know.
I don't see them yet, Dr. Bacon, but
They should be up there now.
not yet.
Okay, let's go back. And once again, a technical issue. Share, let's go share. Failed to start. Let's go back again. Is this where someone in the group should keep the conversation going?
Well, while you're working on the screen share, maybe I'll jump in right now and talk a little bit about where we stand for vaccines for the judiciary.
Sure.
We've been working very closely on a daily basis with the Department of Public Health, and we've worked very hard to get our get lined up or get in line with everyone else for vaccines. Obviously, there are priority categories which the state is taking care of right now. People in senior homes, people who are frontline, first responders, and those priority people, people over 65, those people, they still got a ways to go to work their way down those ranks. So until those ranks get worked down, the judiciary is in a holding pattern. We had hoped early on to start vaccinating people in the judiciary as early as late January and early February. But that's not going to occur, obviously, because these other priority groups are still getting their vaccinations first. We will be the first to tell everyone when it's time, when we're going to have vaccination events at the courthouses. But in the interim, while we wait from word from DPH that vaccines are available to us, I strongly recommend that anyone who is in that over 65 category or falls within any other categories that are currently being vaccinated, go through the DPH and the state website to get yourself a place in line and get vaccinated at one of these statewide events. We'll let you know just the minute we know that vaccine is available to the judiciary. With that, Dr. Bacon, take it away.
I trust we're adequately showing now. I appreciate that.
Yep.
So thank you for your patience. I want to thank a couple people. Number one, Sean O'Sullivan from the judiciary system did an excellent job preparing some of these slides and also made them a little more upscale. And Marcy Dries, who's our chief epidemiologist at Christiana, shared her recent talk on vaccines with me, and was I've updated some of that discussion. You'll see those slides as we move through. My hope today is to cover the current epidemiology of COVID in the state of Delaware, talk quickly about the current treatments. There are a couple of new issues, particularly in the outpatient arena. I think everyone is eager to hear about vaccine status. I'm going to share what we know about vaccine status currently. It's a moving, fluid environment with vaccine status, particularly with respect to the variant strains. And I'll talk about the variants a little bit and what that may or may not mean when it comes to vaccine data. And then I think we have some questions that were offered from multiple sites hopefully respond to some of those questions. And Chief Justice will also, once again, review some data on vaccine status with respect to your organization when we get there. The obvious trend, as you recall, we met some time ago, and we've met a couple times since. This is back in May, and then clearly we had the summer quieted down a little bit, and this is national data. And then certainly the fall beginning of school returning. And as you'll see at the end of this slide, the fall worsening. This is clearly Thanksgiving and Christmas holiday bumps that were expected. The surges were there. Starting to wind down at this point in time. Those surges were expected, and I think well described individuals. And the next surge I would be cautious about for everyone on this call is the 30% of humans in the United States that plan to attend Super Bowl parties in person. That is, I believe, quite risky, high risk environment. Drinking, eating, consuming, yelling, screaming, all those events occur in a closed space. We will then again see a turn upward again in the numbers. In Delaware, our curve matches the national trend. As you can see, this was certainly a curve that by the end of the year, the large surge, and now we're seeing a downward trend reflected in the numbers. Current status in Delaware is about 280 new cases per day. Delaware overall, however, has experienced 1,100 deaths from COVID since the beginning. I'll remind you that influenza per year deaths are in the 20 to 40 range. So we're talking about a huge difference in virulence and pathophysiology and death rate with this disease compared to, quote, influenza. So it's not simply influenza. So we are seeing a decline in hospitalizations, decline in numbers, but obviously we're still in a difficult lockdown type situation. Total deaths by age, I think it's important to notice that over 65 is the highest death rate, we know that. But frankly, in this current arena, the surges from holiday and January, I'm seeing a lot of families coming in. I'm seeing parents dying. I've seen children die right before their parents die. I'm being pretty blunt here. So the age 35 to 50 is not immune to the death through COVID, and age 50 to 64 is certainly a population, particularly in those with high risk comorbid conditions, diabetes, elevated basal metabolic size, large individuals, hypertensives. This is confusing information, but I think it may be very telling. Looking at the current data in Delaware in terms of number of percent of persons testing positive, this is as close as you were going to get to a prevalence of the virus in the population base. This looks at all the testing done and all those individuals that are positive for those tests, not by individual tests, but if one individual has 2 negatives and 1 positive, that's a person positive. And the data from the fall in November clearly shows a rise in those numbers. If you look at the current data in January, we're seeing those numbers flatten out, but we still have a 22% to 24% positivity rate among populations being tested. There's still a lot of virus out there, a lot of mixing of virus with other people, and it's also the asymptomatic population that's likely spreading this. That hasn't changed from before. The percent of positive tests that are done are still in the range of 7% or so. So there's an ongoing smoldering activity of this virus. The relative reproductive rate of the virus is an important number. And if you look at this by state, I hope you can all see the portion of the slide that I think is important. This is the number of cases that develop from one case. For example, if case number 1 infects other individuals and more than one individual, the relative reproductive rate goes above 1. If the case infects fewer than one other individual, the reproductive rate goes down. A reproductive rate over 1 suggests it will continue to spread. Under 1 suggests that you're quieting your prevalence in society. Delaware ranks close to 5th or 6th in the country in relative reproductive rate in terms of a higher rate. We're currently at a high reproductive rate of about 1.17%, 1.17, rate, which means for every infection, at least 1 or 2 more individuals become infected. That suggests continued spread of virus. That's somewhat disappointing. I think it speaks to the fatigue of isolation and the aggressiveness of this virus. I'm not sure how much of this relates to the new variants, which we know are in Delaware. It's clear the Brazil variant's here, the South African variant's here, the UK variant is here as well. That doesn't mean those variants traveled to Delaware. It means that a mutation occurred within our population that's similar to those variants. The venues where people are being infected remains an important discussion. Of the 6,000 cases described in this DPH slide, over 1,400 were viruses acquired in restaurants. Eating, being close in closed spaces, this is clearly evident data. The religious services are not all related to worship services. Many of those religious services, people acquire disease, are choirs and singing services and closed community services. I'm sure that you're aware that most houses of worship are open now with markedly reduced occupancy rates, which are very appropriate. And I can't speak for individual sites. I'm not aware of all the tourist attractions we have in Delaware. Perhaps we have more over the last 3 months than we had before, but that's also another point. And the gym remains a high risk. Just to point out what we're currently testing people for in the state of Delaware, we now are moving from just COVID testing because it's the winter. We now have rapid diagnostic testing that has gone live and is actually able to detect COVID, influenza A, B, and RSV. These are the big respiratory viral pathogens. So we can now screen for flu at the same time we're screening for COVID. I will also tell you, this is an important sentinel comment. I've not seen a case of, I've seen one case of influenza with COVID some time ago. We are not seeing significant rates of influenza yet. Delaware tends to peak late, usually February into March. So it may be early, but I guarantee you that the current masking, social distancing, hand washing, decreased volume of humans in spaces is clearly benefiting us with diminished influenza exposure and activity. Now, some essential personnel sites have changed their quarantine guidance as well. Quarantine, by the way, is if you've been exposed to the virus, you quote quarantine for 14 days typically, because the post-exposure risk of developing disease is day 2 to day 14 typically. Isolation is when someone's actively sick, you isolate them to prevent spread. If you are actively sick, you're isolated for 10 days typically with mild to moderate disease. If you have underlying immune disease or have severe disease or hospitalized, for example, it may be as long as 20 days. That's a provider discussion. However, new quarantine guidance in essential workers is if you've been exposed to the virus, you can return to an active environment as early as 7 days if you've been tested negative for that virus, day 5 to 6 post-exposure, with a good test. And there's some discussion about testing, which will probably be held in the questions session. So there's a push now to decrease quarantine timeframe based on negative testing. There's risk in that. Because there's risk in that, all individuals who've been exposed should continue to wear masks, social distance, hand wash, avoid crowds and congested areas. 10 people in a 30 square foot, 40 square foot conference room. Now, I want to bring up 2 new interventions. Most importantly, the COVID-19 monoclonal antibody you may be reading about. This is certainly well known because sort of high profile individuals have received this early in disease. The monoclonal antibody, there's one from a company called Regeneron and Eli Lilly, are antibodies that are produced in a test tube, and they are active at binding the virus. The goal of this antibody therapy is to bind to the virus during the acute phase of disease to prevent the disease from progressing. It is best used in individuals day 0 to 10 following exposure or turning positive with the virus. So if you come in contact with someone with the virus, you then test positive. If you're relatively asymptomatic or have few symptoms, but are a high-risk individual, weight issues, diabetes, hypertension, all those things would put you in a class of potential risk. You would then be a candidate to receive the monoclonal antibody infusion. It's a one-time infusion, approximately an hour and a half infusion. And in theory, it prevents hospitalization or progression of disease. The data is quite impressive with this. In the New England Journal paper this month, of 450 people infused with the antibody had high risk factor groups. Of those, very few adverse events, number 1. And number 2, it decreased the viral load by 2 logs, almost a 100-fold decrease of the level of virus in your system. It decreased hospitalizations in the higher risk group from 14% expected hospitalizations down to 4% in the higher risk group. This placebo-controlled trial makes it very valid. In the non-high risk groups, 6% were hospitalized versus 1.3%, a fourfold decrease in hospitalization. That's a major intervention in this disease. And Christiana that I work with, I know has infused about close to 300 to 350 individuals with this monoclonal and have had good success, I think, preventing hospitalization. That's a new intervention over the last 6 weeks. The current acute interventions remain the same. In the inpatient acute side, you'll hear about the use of steroids remaining clearly the indication with most efficacy. Number 2, remdesivir remains in the armamentarium. Most of us believe it gives a little kick, maybe 3 to 4% decreased mortality. And then we're using agents called IL-6 blockers, which are really giant Tylenols, intravenous Tylenols, to break the immune response and the storm that inflammation the virus causes, minimize lung injury. We're also seeing an awful lot of blood clots in this population, so anticoagulation is an increasingly important intervention in the acutely ill sick patient. This is obviously a schematic of the virus with the outer spike protein. This is the spike protein that binds to the ACE receptor on the surface of the cell in your organs that the virus affects. This spike protein is where the vaccines are designed to affect change and bind to prevent binding and to prevent progression of disease. It's also the spike protein the monoclonal antibody is directed against. It's also the spike protein where the variants are showing some changes. We'll talk about that. So, what do we want a vaccine to do? Number 1, we like a vaccine to prevent infection. Number 2, we like a vaccine to prevent individuals who are acquiring it from becoming symptomatic. So you want to avoid acquiring disease. You want to avoid becoming symptomatic from asymptomatic. And part of that too, if the vaccine can ameliorate disease, you'd like it to prevent hospitalizations, obviously prevent deaths. It's really hard to detect if a vaccine can prevent an infection. I think the data clearly shows it does based on the current data. I also think the vaccine it's hard to show that it prevents hospitalizations or deaths, but you need a large population studied to show that that's the case. I think you'll see with the Moderna, the Pfizer, and probably the Johnson & Johnson and the AstraZeneca vaccines, this data is quite impressive on all these fronts. But the key is at least trying to keep people go from being asymptomatic to symptomatic. When you become symptomatic, you're spreading far more virus, and therefore the viral load among the population is higher. The hope is that a vaccine will decrease transmission, decrease symptomatic episodes, decrease volume of virus in your system, and therefore decrease risk for other individuals. And that reproductive number will drop from 1.7 to well below 1. There's also a discussion of herd immunity. This is an important take-home discussion. Herd immunity is when there's enough of a population immune to a disease through vaccination or natural immunity, you prevent other individuals from getting disease. For example, if you're sitting in an auditorium and there are 100 people in the auditorium and the first 8 rows are all immune, then the last 3 rows, the other 20% of people, will not get the disease because they can't get through that barrier of those immune individuals. Plus, if you have a certain population immune, that decreases the load and shedding and spread of the virus. Now, for every disease entity, I didn't realize this till discussion started. For every disease entity, there's a variation in terms of how much herd immunity is appropriate. For example, with measles, it's a very virulent bug, transmitted easily through the air, airborne. You need to have a 95% herd immunity to prevent measles in the population in general. That's a lot of people. That's why it's such a hallmark of immunization of the child and should not be foregone. Polio, about 80%, is not as virulent as that. No one knows for COVID. The number may be 50 to 70%. We just don't know. And so no one's going to be able to tell you that 70% herd immunity will fix this issue. The thinking is that it will, but once again, our thinking has to change as we learn more about this virus. And the current estimate for the US population is about 10% of the United States population is currently immune to the virus, or less than 10%. I've heard that number all over the place. I like the 10% number, it makes sense. If you look at the prevalence in the Delaware population of those being tested at 28%, well, if you extrapolate that to the general population, I'm hoping that we have 5 to 10% that have already had disease or been immunized or are immune. We've had about, I think, 78,000 cases in Delaware. So that's less than 10% of the population. So the other comment is that attempts to increase herd immunity by facilitating exposure to individuals in the clinical setting, or to suggest that let's all get sick, is not a very good idea. And I can give you clinical anecdotes where it's not a good idea, where I now have families coming in the door, multiple family members sick because the young individuals thought that they'd be successfully moved through this disease state, and they pass it on to their older individuals in the family with just heartbreaking outcomes, frankly. On to the discussion my guess is everyone would like to have. This is a screen of all the current, I think, potential vaccines you'll be hearing about and hopefully receiving. We all know the Moderna vaccine is out, the Pfizer vaccine is out, and they've been in the Delaware arena already. I believe Delaware had around 130,000 vaccines supplied, and they've hit about 85% of the initial, 85% of those vaccines have been given. So about 20,000 left to go is my understanding. That's a changing number, and I think that's important to hear. Both the Moderna and the Pfizer are very sophisticated mRNA vaccines, where the mRNA, which is the messenger RNA that creates the spike protein, is injected into your arm smooth muscle. Your arm smooth muscle cells, the muscle cells then generate the spike protein. You can't get COVID from this vaccine, but you get a really brisk immune response. And my arm it reminds me every day how brisk that immune response. It hurt for 3 weeks afterwards. So you generate the immune response, and it's a very successful immune response. This is a highly efficacious vaccine with 95% efficacy. And not only that, but those that still get disease are not hospitalized and are not acutely ill and don't require aggressive care. It's one of the most impressive rollouts you can imagine. Scientifically, this is really a sentinel event. This disease state brought us. Every illness, for example, AIDS, the downstream effect of AIDS scientifically will be felt for decades to come in terms of therapeutic interventions and scientific studies. This will be a similar concept of vaccine development. The next vaccine to talk about probably is the AZ and the Janssen vaccine. The Janssen vaccine is the same as Johnson & Johnson. These are not the same as the mRNA vaccines. They are vector vaccines. There's a dead or inactivated adenovirus that contains actually DNA, not messenger RNA, that correlates with the spike protein. And they inject the adenovirus into your arm, and then your body, once again, takes that DNA, generates a spike protein, and then you generate an immune response to that. These are extremely effective vaccines if you look at how you judge a vaccine's efficacy. And we'll talk about some of the numbers, but the J&J vaccine is hitting at least 85% of US strains of the virus and up to 60% of the variant strains of the virus. That's going to be the key issue, is how can we affect the variant strain as well? The key to the J&J and the AstraZeneca vaccine is easily mass-produced. Distribution is nowhere near as complicated as the Moderna and Pfizer because they don't require cold storage. And the J&J vaccine is a single-dose vaccine. This is a vaccine for the world to receive. This is a vaccine to be distributed promptly, and immunization can occur quickly, safely, and distribution of vaccine, I think, is a key issue here. Pay attention to the Johnson & Johnson vaccine. I think that's the next one that we'll see here in Delaware. It's going to move for emergency use authorization very quickly. And the AZ vaccine will not be far behind, I think. They have very similar data. The Novavax has some really good data. I don't know the current numbers in terms of efficacy of Novavax. I've heard it's about 60%, particularly with the variants. I love this slide. You want to be in the blue line, not the red line. This is the Pfizer mRNA vaccine data, showing the red line being those that receive placebo or no vaccination, the blue line being those that receive vaccination. And if you look at the time frame of this, it's a 2-dose vaccine, day 0 and day 21. And within 7 days, a separation occurred between vaccinated and unvaccinated populations. The ultimate number, this is a 40,000 human trial. Ultimate number was 172 people in the placebo group became ill with COVID. I think 9 people in the vaccinated group became ill with COVID, suggesting that it clearly protects you quickly, right away. One dose is efficacious enough, frankly. And that's another discussion to have. You know, should you wait for your other doses or one dose enough? I think the key is vaccinating as many people as you can, as quickly as you can, with anything you can. The other key take home from the Pfizer study was that of the cases that were severely ill, requiring hospitalization or requiring a lot of oxygen, in the placebo group, there were 9, 7 of which were hospitalized and 3 of which went to the ICU, severe disease. In the vaccine group, only 1 person required oxygen supplementation, was not hospitalized. Highly efficacious, decreases the asymptomatic to symptomatic push. Moderna data shows the same data, 95% efficacy. Very few people became ill. Of the 95 cases and the 30,000 people in that trial, 90 in the placebo group were ill, 5 in the vaccine group were ill. And all the severe cases were in the placebo group. Speaks to being in that blue line. I brought this slide up to talk about the tolerance of the vaccine. Really very few side effects. And you may be seeing some stuff about people having codes and doing poorly. Keep in mind the number of vaccines that have been given worldwide now are large. And so you have to look at the end. Injection site pain is common. Fatigue is very common, 10% fatigue. And those of you that have been vaccinated, I was exhausted for about a week or so after my vaccination, but that's just one person. I'm still having arm pain from it, but it's very tolerable. I think it's well worth it. Everyone has to make their own decision on those lines, but I think it's clearly efficacious, very safe, and I think warranted. I'm going to let Chief Justice Seitz discuss the vaccine rollout and how it relates to your organization. If you let me know, I'll just move the slides when you're ready.
That's great. Thank you, Dr. Bacon. And on those side effects, it's my anecdotal experience with that is the first day or two after them, you have some of these that you were just displaying, but they fade over time. And as you said, the bottom line on these is they're extremely safe. They do cause some of these minor side effects, but overall, there've only been isolated cases of some kind of reaction, and that may be because the person was sensitive to vaccines or something like that. Is that right?
Yes, I agree. It's very short-lived.
Yeah. Okay. Good. So just to follow up on what I was saying before we got the slides going, we're now in phase 1B, and if you'll change the slide, we'll get into a little bit more of the details. As you can, phase 1B includes the people in phase A, and for any of you who have been watching the governor's conferences and Dr. Rattay's conferences, they've explained a lot of this and how it's going. Phase 1A are these healthcare personnel and EMS workers, people like that, long-term care residents. Phase 1B, the state is pretty much still just trying to hit as many people in the 65 and over population right now. Although my understanding is fire, police, teachers, and others are scheduled or are getting their vaccines, as you'll see from this slide. So these frontline, or what I'll call public-facing people who have this day-to-day interaction, have rightly been prioritized by the state. If you could switch the slide, please. You can see that, as Dr. Bacon was saying earlier, Delaware has done a fantastic job of getting, as they say in Britain, jabs done of people in Delaware. So there's not a lot of vaccine just sitting on the shelf waiting to be administered. I saw a chart that said Delaware is in the top 10 of the nation in getting the vaccination out the door and into people's arms. So the governor and his team are to be commended for making sure that the vaccine gets out the door. Next slide, please. So as we've seen in the phase 1, it's broken into A, B, and C. We're in the B right now. Remaining phase 1C will be people in the categories that are listed in this slide. And as you'll see, legal is listed in 1C, but we've been in conversations with DPH, the Department of Public Health here in Delaware, and the judiciary will be treated as part of 1B. So we are going to be treated as part of 1B and not necessarily as 1C. But we're going to have to wait. We're going to have to be patient until some of these other high-risk groups get the vaccine first. As I said earlier, we are in daily contact with DPH. We are set up to administer the vaccine when it's available to us in each of the courthouses in each of the counties. And we'll let people know just the minute we hear from DPH that vaccine will be available for the judiciary. Next slide, please. And the reason that we've been bumped up to 1B for the judiciary, as you can see here, is that under DPA, under the Department of Homeland Security, people in the legal profession have been determined to be essential employees. So it's frustrating to wait. It's hard to wait. And I assure you, we're doing everything we can to make sure that when the vaccine is available to us, we will make sure we administer it quickly and efficiently. But we're not going to jump the line. There are other people that rightly so come before us, and they're still working their way down those people. I think that might be it for me, Dr. Bacon.
Okay, good, thank you. So I didn't want to leave today without talking about the variant strains, which have popped up, that's an odd thing to say. They've developed over the last 3 months, probably present throughout this viral disease state. Keep in mind that every time this virus replicates, there's an opportunity for a change in the RNA makeup of that virus. And some of those changes allow the virus to die and it can't replicate again. Other changes give it more activity in a different arena. The current data that's being published on the variants focuses on the UK, South African variant. We have the Brazil variant as well. What happens with these variants is they have an altered spike protein. And the alteration of that spike protein is interesting, and it makes it a little bit stickier. So that spike protein is able to stick in certain areas better than it would have in the past. That does not change its virulence in terms of its ability to make you sick if you have the virus. I think that the data currently shows that the disease states may or may not be more deadly. I don't think they are. But it certainly makes them more virulent in terms of actively transmitted from one human to the next. If it's a stickier virus, it lives in the trachea longer, develops a higher load of virus in your trachea and upper airway, and therefore you have a higher load expelled when you cough or breathe. So that's what makes it probably 50% more virulent or more easily transmitted. The current data on this is that it is neutralized by current antibodies, including the monoclonal antibody, and it currently is neutralized by the vaccines, although not as strongly as anyone would like. And I think that's going to be the story to watch the next 6 months. As the vaccine rollouts continue, what will we do with the variant strains? I think there's some opportunities there. Number one, the Johnson & Johnson single dose clearly shows activity against the South African strain. That's been documented now, and that's reassuring. We have an 80% efficacy of this vaccine against the US strains, the predominant US strain, and 57% against the South African strain, I think the UK strain as well. The Novavax shows good activity against the UK strain, and the AZ vaccine shows adequately 50 to 60% activity versus the UK strain. So those are certainly reduced activity. The Moderna and the Pfizer are interesting because what the Moderna and Pfizer strains vaccines can do is they can use exchange a different mRNA for that new spike protein mRNA. So they can actually change the injected mRNA and using their same system for delivery. So all these vaccines can adjust to this phenomenon. You don't want to have to adjust. You want this vaccine to minimize risk and transmission as quickly as possible. This will become a race between the vaccine and the variants, frankly. Currently, I think the vaccine is in a good place, but keep in mind the variants will likely become the predominant worldwide population because it allows a selective advantage to those viral strains. So this is why it's fluid, very active arena. I think the vaccines work quite well. 66% is excellent. I would rather have 1,000 people vaccinated at 66% efficacy than 2 people vaccinated or 10 at 95% efficacy. The more we reduce the load of virus in the community, the faster we do that, the better we're all going to be. Also, the J&J vaccine has a shelf life of 2 years. I mean, these new single-dose vaccines, the vector vaccines. Yes, efficacy is not 95%. You don't need 95%. You don't need that efficacy. You need, shots in arms. At that point, I'm going to go over some questions that were forwarded to discuss sort of the vaccine and what to do. First question, should I get the COVID-19 vaccine as soon as it's available to me? Yes. It's a straightforward, simple answer. There are really no strong contraindications to any of these vaccines yet. Some of the vaccines have not been documented to be used in trials in under age 16. There may be some age barriers to vaccination. Those barriers will go away quickly.
But
I think
so, Doctor, at least
vaccine.
as of now, Doctor, is it's not approved for 16 and under? Do I have that correct?
Yes, but my suspicion is we'll see it broaden its approval as it goes through safety trials and over time if it's been immunized with enough people. Should I get the vaccine if I've already had COVID-19? I get to ask that question all the time on rounds. And the answer is yes. The data does show that if you have active natural disease with COVID, we do know that you're protected from getting it again for at least 3 months, and current studies show up to 6 months. So number one, you don't need the vaccine for 90 days. And number two, having had COVID is unlikely to change your ability to get immunity from the vaccine. So there's no reason not to get the vaccine. So there's no contraindication to being vaccinated, but you don't need it for 90 days. Reinfection can happen. Should I get the vaccine if I currently have COVID? The answer is no. If you currently have COVID, number one, the vaccine's not going to help you with your current COVID episode. It's designed to prevent disease later on. And number two, if you get the vaccine during active COVID disease, some of the interventions may alter your ability to respond to the vaccine. So it would not be worth your time to do it. It would be a waste of a vaccine. So if you have COVID, how long should you wait? Minimum 14 days post-COVID. And if you have COVID, we've just said wait 90 days is fine. Should I get the vaccine if I'm pregnant? The answer is yes. WHO just came out endorsing pregnancy vaccination during pregnancy, and every healthcare team I've dealt with and every institution has been vaccinating pregnant women. There's no risk of acquiring disease from this vaccine. With pregnancy, it's not a normal state. Obviously, your immune system is down. You're trying not to, quote, reject the fetus. So it is an immunocompromised state. In the setting of a vaccine that's a live attenuated vaccine, other vaccinations that are potential to become activated, you do not take that vaccination. This is not anywhere near that type of vaccine. So the answer is, if pregnant, get the vaccine. In fact, the numbers show a large number of pregnancies that just was released with no side effects, serious side effects, over 70,000 with no side effects. If I receive a 2-dose vaccine, when do I get my second dose? Obviously, with Pfizer, it's 3 weeks. With Moderna, it's 4. The data does show you can go out to 6 weeks. So I have individuals I've talked to who are traveling, for example. I got my first vaccine dose today. I'm going to be away. I want to get my next vaccine. When do I do? Up to 6 weeks is felt to be efficacious. Keep in mind, you're protected after that first dose also. I think we're going to find spreading that time frame out may be clinically safe, clinically appropriate, and still efficacious. That data is not available yet. I received a first dose of vaccine. Can I get a second dose of the other vaccine? Well, in theory, yes, by the way. Scientifically, I think yes. In terms of practically, that's not the case just yet. If you have a Pfizer, you should get Pfizer. I actually think they're so identical, it's unlikely that you'd find any alteration in their efficacy or any change in reactions to the vaccine. So I think they're relatively interchangeable from my viewpoint. As anyone should not get the COVID vaccine. I think, once again, under age 16, I think there are some trials going on, as this answer says. I can't reason why someone would not get the COVID vaccine. Now, keep in mind, there are some people that get quite febrile afterwards. They're sick for 24 to 48 hours. Some people think that shows it's working, and I would agree with that. What about issues or reported problems? The data is pretty good. It depends where you get your information. Looking at the CDC sites, I've been very comfortable with their response. DPH site has some good information. make sure that you're reading good, reproducible, credible data, frankly. And I think there's a lot of disinformation out there. Side effects I've already gone through: mild fever, some headache, fatigue up to 10%. Arm pain is really prominent. Injection site body aches. Those are the big things for 24 hours. And the other question is, are there medications that interfere with my ability to get the vaccine? You know, I've typically told people to go ahead and take some Tylenol before the vaccine, or Benadryl. That is actually frowned upon by the CDC websites and DPH, particularly ibuprofen, which is not Tylenol, it's a non-steroidal. There's some discussion, I'm not sure it's documented well, that the ibuprofen can, to some extent, blunt your immune response. I'm struggling with that. But for now, I'm telling people don't use ibuprofen or Tylenol before you get vaccinated. But use it afterwards. You may want to use it the next day when the side effects start to kick in. And appropriately for any vaccine system, are there long-term effects of the vaccine? No one can answer this question. And I think that it boils down to the long-term effects of the vaccine, societal effects. If you don't vaccinate, we're going to see a lot of ongoing issues. I'm extremely impressed, and I'm not just saying, I'm very impressed with the efficacy of all those 4 vaccines I've discussed, and very impressed with the safety profile of those vaccines. I wasn't big on a couple of vaccines like the first shingles vaccine that came out. I waited for a while on that one. I think that some of the vaccinations data needs to be fully vetted. I'm very excited about these vaccines. I think everyone should be. There should be nothing that holds you back. Jump at the chance to get them, frankly. Vaccine hesitancy. Why are people hesitant to get vaccines? Usually it's because of lack of firm data, understanding, lack of accessing the right information. Side effect concerns. Is it going to work? Yes. Are there side effects? Yes. Perception of risk and associated costs. I think the costs are dealt with, obviously. I think the vaccine does not cost you anything. Healthcare providers across the board are focusing on the need for this vaccine. And I would clearly encourage that. And that's sort of my last go-to point. With that, I think I'll stop there and answer any additional questions that you might have if I can get back to the right screen. We'll see.
So, Doctor, what about getting other vaccines, like getting the flu vaccine with the COVID vaccine? What's the current thinking on that?
I think the current status is I would wait 2 weeks between vaccinations. I think that we're fortunate that flu was delayed in the state of Delaware. And I think at least 1 week between. The reason you want to wait are, if you want to know if you get a vaccine and a reaction, if it's the actual vaccine doing it or some other illness coming on. I've had some patients who were vaccinated with the first dose of the Pfizer and then became quite ill 2 to 3 days later. And, oh, it's the vaccine, it's the vaccine. Well, they had COVID, actually. So they acquired COVID in a time frame where they were able to get it before the vaccine kicked in, that 7-day mark. So I think it's a 14-day waiting period. I would give at least 14 days before shingles vaccine, 14 days between this and any flu vaccine. I'd have to look up the data in terms of what the CDC recommends, but I think it's probably 14 days.
Okay. And once you get the vaccine, should we all just go out and attend the Super Bowl parties and go back to life as normal?
No. And I actually think that question is really appropriate. I've been vaccinated and I still self-isolate. I have family members that have not been vaccinated. I can still, if I'm vaccinated, I can still acquire disease. I may be asymptomatic. I can still spread disease. Not like before. I'm hoping not like before, and the data shows not like before. But there is still risk. So you've been vaccinated, you can still acquire the virus. You can still have the virus in your upper airway. You'll be asymptomatic, and you can still shed that virus to other people. Continued masking, continued social distancing, continued hand washing will be critical. The goal is not to become blasé about this. The goal is not to allow it to keep smoldering. The goal is to shut this down appropriately. The other question that comes up is, should I be wearing 2 masks? 2 masks are endorsed by some individuals. It's not the official CDC, the WHO guideline yet. I still wear 1 mask. But if you're in a crowded arena and you're in a place where you can't distance well, there's nothing wrong with 2 masks.
Why don't we try and end on a hopeful note, Doctor? And what does the future look like? Does it look like things are going to get better by spring, summer, fall? What when you look and gaze into the crystal ball, the vaccine crystal ball, what's it going to look like for us here in Delaware?
My first hope is that the high risk people are vaccinated and protected. And I think that hopefully is occurring now. I think we'll see into March, we'll see a move toward the essential population getting protected. The frontline people, the EMS, the people that are out there really need this. I think the current push I'm hearing is if we get the single dose J&J vaccine, you get the AZ vaccine out there, continue Moderna, continue the Pfizer, we'll see a lot of vaccinations occur. The first 100 days is obviously the central driven goal, but I think by early summer, we'll have a large population vaccinated. I'm hoping, my own bias is that June, we'll see a significant return to, quote, normalcy. And as we move through May and June, we'll see the vaccine permeate through the population appropriately. And I'm hoping to see some return to activity May, June, which frankly is far better than we had a year ago. And I really think this is not the time to let your guard down. We're almost there. We are almost there. And the healthcare workers I work with and the acute care providers seeing the population become ill and the numbers dwindle downward is reassuring, but don't lose sight of the prize. And I really can't say that strongly enough. I'm hoping May, June, we'll see a real improvement.
That's great. So my takeaways from your helpful comments are: watch the Super Bowl parties. You know, for a couple hours of joy can bring so much heartbreak. You've seen it. You see it every day in the hospital. You see it happen to families. It's just not worth it. We are getting to the end of this tunnel. People need to double down. The other advice I take away is if you get the opportunity to get any of the vaccines, take any of the vaccines. It's not about 95% or 65% or 85%. My understanding is most of these vaccines are going to keep you out of the hospital and keep you from dying. So if you get the chance to get a vaccine, get it. And hopefully by summertime, Dr. Bacon will have some concluding town hall with you, and we'll maybe do it in person.
I appreciate that. And I agree. That's a wonderful thing to hope for.
All right.
Thank you.
Thank you so much. And thank you, Doctor, for your service to the people in Delaware, especially all the people that are so seriously ill from the virus in the hospital. Thank you.
No, thank you. I appreciate it.
All right.